I want to invite, in this session we have Joe Cookson from WHO, who we've already met. We have Teresa from Rwanda. Okay, at least let me invite Joe to start his presentation on the state of the art to do with intelligent health systems, monitoring, evaluation, and operational research. Thank you.
The idea behind this session around intelligent health systems, there's been a lot of focus on monitoring, and I'll say something about that, but I want to talk in particular about evaluation, which we use in the expression M&E, but often don't really focus on. So just quickly, some of the core concepts and the definition. I mean, without going into big detail, the fundamental difference in a way is monitoring is for tracking progress. And in a sense, monitoring can essentially describe change. Some, utilization has gone up and down, or financial protection has improved or not. What monitoring can't do is explain change. Indicators alone can't do that, and that's really why evaluation is needed. Evaluation, or sometimes referred to as applied policy research. For that, you need a good description of the specific implementation process, a methodology as well that's linked to that implementation process. And fundamentally, you're trying to get at causality with evaluation. If you want to know if your reforms are working or not, it's really, monitoring is not enough. It's essential, and especially if you want to learn from them, which I think is the focus of this. Doing applied policy research on reforms is essential. One thing I wanted to do here, and I was asked to do here as well, is say a bit about what's happening globally as well on this agenda. Most of this is monitoring, but this part is more of a causal framework that we've developed jointly with the World Bank on UHC, in effect. But it's really going here, because you can see if this will work, from the inputs, which are effectively here the building blocks of health systems, to outputs, or what is produced, in a sense, by the health system. The outcomes of interest, so the coverage of services, financial protection, addressing risk factors, and then the ultimate impact. practice, and this is kind of a textbook version of how one would go about a policy process. So it's not necessarily followed in practice, but one starts with some definition of what the problem is, goes to causes, look at options, and then there's a decision made based on this analysis, like we've done the health financing situation analysis and strategy. Then there's implementation, evaluation to accompany that, and then adjustment. So that's the ideal, and we'll come back at the end to what may happen in practice. I think the important message from this is to think about your health reform plans, your health financing strategies, as essentially a set of hypotheses, right? That if we do these changes, first of all, we're doing them for a reason, be justified by some plausible impact on the problems you're trying to address. And if you can't make that case, then there's a real question about why you're doing those reforms. And it's important so that reform doesn't become an objective of itself, right? That it has to be addressed to a problem. I think the key message, though, is, and Lydia pointed to this at the beginning, is not to wait. And I'm going to give an example of this from where I worked in Kyrgyzstan, which basically is an issue where in Kyrgyzstan, one of the problems that they faced was informal payment. So services were supposed to be quite low cost, but everybody, by 2000, it was clear that everyone was really paying a lot out of pocket. And one thing that they had in the system was a series of exemptions from these co-payments or user fees, but there was belief that they didn't work. And so part of the reform agenda was introducing new provider payment methods, which would, among other things, pay providers more to treat people in exempt groups. So the hypothesis was that, if you treat these people more, then they will both use services and that their out-of-pocket payments will go down. The reform itself was implemented on a phased basis, so it began in 2 of the country's 7 regions in the first year and then was gradually rolled out. So the combination of what they wanted to achieve, the hypothesis around the reform, and also the implementation strategy lent itself to a particular method. So basically what we were able to do was using the hospital database of the National Health Insurance Fund. And the hospital database included all of the patient discharge data for all cases, whether people were insured or not. They had a unified national database. We could draw a sample from that, knowing who was in exempt categories and not exempt categories. And we did a baseline survey of them to see what did people in exempt groups and non-exempt groups, what were they paying out of pocket. This was for the month before the reform was implemented, and then and this was the month, or 6 months or so later. It was an early analysis. And basically what it was showing was that we could compare basically the regions where the reform was implemented to the other regions where it wasn't implemented, and then what happened to payments by people in exempt group here compared to here. And this was important because the only difference between the reforming regions and the non-reforming regions was the new provider payment method. Exemption categories, everything else was the same. So we felt pretty confident seeing this, that the reform was having some impact. And I just use this example to say that this is a very tailored approach, which is what you need to do, and depends critically on how you're implementing things and what problem it is that you want to look at. So this was really just an example of that. So that was just one bit of content. I think also very importantly is to say, what does it take not just to do a study, but to really institutionalize this process in your health system? And like trying to be a good economist, I believe supply and demand are important. Supply we think about a lot, in that we have people trained over courses and come back with masters or PhDs and can do policy analysis. So the supply of people who can do this type of work is important. We find that demand matters a lot. If the policymakers don't own it, if they're not seeing the value of this work to them, and we can say both the technical level of this, that people can adjust and adapt policy over time based on this feedback, but also the need for public accountability And potentially, if the reforms are working, to help you sell and market this, that we can really demonstrate this. This is quite important. But we found that supply and demand are not enough, sad to say, and we need to think about the institutional arrangements. And two specific features that will have different solutions in different countries, but are very important to think about. One is the ability to attract and retain people with these skills, which is very hard to do in most countries on a core civil service salary, why a lot of people run off to work for WHO or USAID or the World Bank or others. So we need to think about that if we're really going to institutionalize it. And then the last point, very important as well, that this type of work needs to be close enough to the decision makers that it's actually relevant to the policy concerns you have, but a bit far enough away so that there can be independence in doing good objective work. And so there's a tension there, and as we said, there's not a one-off, or there's not a single answer to that, but thinking about how to do this and thinking about these objectives maybe is a way to think about next steps in your country. One thing as well that I think is very important is timeliness, and I have a story which I'm going to tell briefly about a problem I faced in Kyrgyzstan. It was around the analysis of this co-payment change. And basically, using the phasing and so forth that I described, the minister was very keen that we do this analysis of a policy that included a formal co-payment to try and address informal payments that were taking place in the country.
as an agency, we decided to This is currently just to show what the percentages are of people who are registered and the claims payment trend over the years. So, in January 2014, in collaboration with HFG, we decided that this is a key area we need to look at. By May, we had our own multi-stakeholder workshop internally, where all the directorates were brought together. And we decided to look at our strategic plan and our core mandate. And we asked ourselves, what do we need to be looking at to make sure we are succeeding as an authority? From that initial discussion, a core team was put together in June of that year to try to identify 10 specific indicators. And these indicators, we had some, key things that we needed to look at for that indicator to be included on the dashboard. So, as I said, it was based on the objectives of the authority and the ministry as a whole. All the directorates were represented in the initial workshop. The indicators had to be aligned to a thematic area or thematic objective of the authority. It had to measure performance in some way, and the indicator had to be something that was actionable if a problem was identified. We didn't want to measure things that are just need to know or good to know. It had to be something that if a trend was seen, an intervention was appropriate. So, once we had kind of agreed the indicators, then the technical team had to look at each indicator and ask themselves some questions. How easy is it to have this indicator produced? What are the business requirements to ensure that this indicator is always available and reliable? And how would you visualize the data? It can't be in Excel spreadsheets or something. And then for each indicator, you needed to identify the source, the quality, and any challenges that the authority may have in having this indicator available. So we developed this indicator rubric and scored every indicator on these points. I'm sure you can read it through, but 1 point is easy, medium 3 points, hard 5 points, and we looked through the clarity. You'd be surprised how we all say membership or active membership. And you talk to 5 different people, and they all have a different definition of what that active membership is. So we went through everything to make sure we all agreed what that indicator even means before you start looking at the data sources and reliability. And by the end of it, for the indicators we had totaled up the scores. And if it's between 5 and 12 points, it's easy. We can do it. We're good to go. Anything else, it meant the authority had to take a decision. We're not ready for this. We need to look for some other indicator to measure this area, or we need to invest in a way to get that data available. So the initial indicators were looking at the active membership. We're looking at equity, the categories that are coming up. For the biometric, as you know, we're going to capitation. We needed to make sure that, one, people are captured on the biometric and they've chosen their preferred primary provider, which would allow us to start the capitation payments. And then, obviously, claims liability. Every insurance is interested in claims liability. So, the active members, we were looking at just general coverage in an area versus the population of that area, which data is obtained from statistical services. Then the percentage of indigents covered. We have social welfare and other surveys that have told us what the percentage of core poor is in the country. And then geographical distribution. Why are some areas unable to reach our average 40%? And this is just a sample visualization. These are the regions, and you needed to be sure that everybody who is an active member has a biometric registration, and in the areas where the percentage is low, do we need more kits? Do we need to have mobile registration? There's an immediate intervention you can put in to change the data you have. Then the choice of PPP. If people haven't chosen their PPP, how do you pay the capitation payment to a provider? This is an immediate visualization. We can see some areas, 100%, everybody's chosen a PPP. You know who to pay their capitation payments to. And you have some where not even 20% have chosen a PPP. Capitation won't work in that area. Immediately, you know the area to flag and intervene. We can't wait to look at the data in 6 months' time on an Excel spreadsheet. And then the claims liability. You know, the total IPD, total OPD, you can see the drugs and service and the percentages. When this is just the total, but if you were to break it up by region or by district, you can easily flag the areas where the medicine component is so high. And then, obviously, this cannot tell me why, but it's a flag for operational research or the research department to quickly design something that will answer the question why, and then we can put in an intervention. You start off with your data, you do some analysis, and there's a finding, which gives you a question. It is passed over to the operational research people to answer the question, why are you seeing this type of data? We design an intervention. The data is still being collected, so then the analysis will tell us, has anything changed? Was that the right intervention? And the cycle continues. This is, for us internally, we've really, for the operations research, we've set out proper phases as to how we go about this. We have a standing technical committee, which isn't it is headed by the research department, but we've made sure we've got technical members from other key directorates in there. And we made sure the committee is small enough that they can get things done fast. And for operational research, it's got to be something that you can have an answer within 3 months. Anything else, we're looking to partner academic institutions or something to do. Once their proposal is done, then we actually go ahead and implement whatever study they're doing. And then the findings are passed to management or whatever, and we all come up with the policy or operational change to address the problem. So our conclusion is that we have so much data. It doesn't have to be the minute details. People say, well, your claims data is not capturing every medicine. You don't need to know every single medicine at this point in our cycle, but we have the headline data that we can capture and make interventions on. And as you feed back and people realize the value of data collection, then you can get more, you can persuade them to give you more detailed data, better quality data. Our district offices, before the dashboard, the data was patchy. You can issue people queries, threaten them or whatever. But once they know the CEO has a dashboard that tells him exactly the active membership at any time by categories, everybody is sitting up. You know you have to reach a target of 15% indigents. If you're not achieving it, somebody is going to ask you why. If you are registering 40, 50% indigents, somebody is going to ask you why. And this we have found to be a much better way of monitoring our progress and getting change to happen. Decision making. For Ghana, health insurance has been very much political, gut feeling, social type of strategy. But I think after 10 years, we've gone beyond that. We are now going to be evidence-based. We need to be able to tell those at the very top, this is the evidence, this is the impact. If we want to achieve UHC, those gut feeling, political decision-making has to stop. And we work really on evidence. Thank you. Teresa, if you could, you have 5 minutes to kindly tell us what Rwanda is doing in this area of monitoring and evaluation.
Ok, merci beaucoup. Je vais en 5 minutes expliquer un peu à propos de, c'est comme un exemple de comment on fait le suivi pour les mutuelles de santé au Rwanda. So the next slide. Peut-être avant d'aller directement à l'outil que je vais expliquer, j'aimerais dire qu'au Rwanda, il y a, avant quelques années, ça fait peut-être 4 ans ou 3 ans, il y avait plusieurs bases de données au niveau des districts, pour les hôpitaux, pour les centres de santé et pour autres, notamment les HMIS, dont nous avez demandé de parler. Mais après, il y a eu un effort de tout mettre, de tout harmoniser et d'avoir au niveau des districts comme un dashboard ou bien comme un portail qui facilite l'analyse des données venant de tout ce qui concerne le secteur de la santé dans le district. C'est ce qu'on appelle DHIS2. Mais je ne vais pas y traîner parce que on m'a demandé d'expliquer plus comment ces analyses, donc bien ces données sont utilisées. Donc, les mutuelles de santé utilisent ou bien ont utilisé les 3 années ou bien les 4 années passées parce que maintenant, avec le changement, on doit adapter beaucoup de choses. Un outil qu'on appelle Financial Modeling Tool. Et cet outil, au fait, sert à 2 choses. Il y a le reporting ou bien le rapportage et il y a aussi les projections pour l'avenir dans une année. Alors, c'est un outil qui a été développé par MSH. On collecte les données de plusieurs sortes. Je ne vais pas y traîner. C'est presque les mêmes données qui sont collectées partout. Le Ghana en a parlé, notamment les memberships, les revenus, les dépenses et tout ça. Je vais traîner plus sur ce qu'on en fait. Alors, chaque mois que ces données sont collectées, les messages clés que je vais donner ici, c'est que d'abord, cet outil permet la prise de décision à tous les niveaux et pas seulement au niveau central. Donc, que ce soit au niveau de la section qui entre les données, que ce soit au niveau du district qui supervise en moyenne 15 sections et que ce soit au niveau national. The next slide. En fait, après la collecte de ces données, il y a des rapports autogénérés, auto-generated reports. Et à chaque niveau, tu peux voir ce que tu as entré, ou bien actual data. Disons, si on est en février, tu as commencé en janvier. Tu peux voir jusqu'en février où j'en suis en termes de de revenus, en termes de couverture, tout ça. Et cet outil te permet de voir, avec cette allure, où est-ce que je peux en arriver en 12 mois. C'est-à-dire, tu commences déjà à comparer là où tu es avec les targets ou bien les objectifs que tu t'étais fixés. Et donc, on te montre, je ne sais pas si c'est très visible, pour chaque section, il y a 4 colonnes. La première colonne, c'est là où tu en es aujourd'hui. La deuxième colonne, c'est là où tu devrais être en considérant les projections qui étaient fixées au départ, ou bien les assumptions qu'on avait au départ. Et la quatrième colonne, ça te montre qu'est-ce que tu peux ajouter, ou bien qu'est-ce qui peut se passer dans les mois à venir, et qu'est-ce qu'il doit être à la fin de l'année. Donc, en bref, ça te donne la situation actuelle et ça te montre un peu si tu as des gaps à couvrir ou bien autre chose. Il y a dans ce rapport autogénéré, on avait utilisé les couleurs pour que ça soit vraiment facile à comprendre pour les gens même de niveau le plus bas. Quand c'est rouge, ça signifie fais attention ou bien il y a une action à prendre maintenant même. Et quand c'est vert, ça signifie tu es dans les normes selon ce que tu t'étais fixé au départ. Bref, si je donne juste un petit exemple, avant qu'on commence cet outil, souvent c'était à la fin de l'année que les mutuelles de santé au niveau des districts se rendaient compte qu'ils ne pouvaient pas couvrir les dépenses de cette année. Mais avec cet outil, chaque mois, ils pouvaient faire attention et voir qu'il y a une augmentation rapide dans la facturation. Et est-ce que c'est un overbilling ou bien une surfacturation? Est-ce que c'est une utilisation qui est élevée? Et ils faisaient des recherches rapidement pour pouvoir corriger avant que l'année ne se termine. Ou bien informer le ministère qu'ils pensent qu'ils ne vont pas couvrir toute l'année. Et pour la couverture aussi, c'est la même chose. Chaque mois, on pouvait savoir, est-ce que je suis en train, à cette allure, je vais pouvoir arriver à mon objectif, ou bien je dois accélérer, ou bien je suis à l'aise. Donc, bref, l'avantage de cet outil, c'est que ces données sont utilisées non pas à la fin de la période, non pas par seulement le niveau central, mais à tous les niveaux et à chaque moment. Merci.
Thank you. I will try to explain how we use to have information system management in Ethiopia. Previously, before 5 and 6 years back, the implementation of healthcare services and health insurance schemes were not very well coordinated. So as a result, the data were collected, they were analyzed, and they were interpreted and disseminated by different parties in implementing healthcare service. After that, Ethiopia has managed to develop a well-coordinated HMIS system in the motto of one report, one plan, and one budgeting. So that at health facility level, we have every registration book that includes preferred indicators by any implementing partner and the Federal Ministry of Health. So all indicators are put into one registration book, and in that registration book, every activity performed by the health facility is recorded. When you go to the community, there is, we have in Ethiopia 2 health extension workers for every village, for 5,000 population. So health extension workers have family folder. We call it family folder, a folder that is used to register every social, demographic, and health service utilization records at the family folder. So these are merely the 2 sources of information throughout the health system. So information from community-based, community level through family folder goes to the district and to regions and then to federal. Any information goes to from family, from health facility to federal level step by step. So that now we have a well-organized HMIS system. it's not possible to either include or subtract any information which comes from community level to higher level. But if the total indicators that was chosen and agreed upon are only 120 indicators about all over the healthcare services. As a result, now the two sources, the family folder and the facility registration books, are becoming the sources for reporting, the sources for researches, and twice or 4 times a year, if anybody from the Ministry of Health or from other partners want to validate the reported data, so they have to go and refer to the family folder and to the registration books. So we are making extraordinary effort to make the data to be utilized at each level. For example, at community level, at facility level, at regional level, and at federal level. So far, we have encouraging result in getting data compiled very well and producing the feedback at federal level. At federal level, we have a system of providing very well organized feedback mechanism through flagship, like Ethiopian's flag is green, yellow, and red. The green is just in a good indicates good condition. The yellow is average, and the red is in danger. So we provide feedback to the regions according to their performance, whether they are in green, in yellow, or in red. So this is provided, feedback is provided to regional health bureaus. We have 9 regions to regional health bureaus every month. And quarterly, the accumulation of the 3 months feedback is compiled, and this is provided to the regional political leaders, regional administrators, regional presidents, so that the political leaders come into awareness. And every quarter we have we have also the JSCC, like the Joint Steering Committee meeting, which discusses on the indicator performances, comprises the ministries and the regional bureau heads. So I think I am running out of time. The problem that we have is these indicators are revised every 5 years, so that we don't have adequate indicators in the community-based health insurance and in the social health insurance, and utilization at lower level is very poor. Thank you very much.
Thank you. Now that the panel members have all brought out their contributions, I think we'll use the first 10 minutes to take questions on clarifications or any other issues that may come from the floor.
Merci bien. Barthélémy Sévégan, Bénin. C'est très enrichissant les présentations. La préoccupation que j'ai pour nous qui sommes en train de commencer, c'est qu'on nous dise un peu au niveau de chaque pays la constitution de ces équipes de collecte et de gestion des informations. Comment est-ce que c'est constitué et par niveau pour qu'on ait au niveau national les informations d'appréciation et d'analyse de l'évolution de la situation. En termes de ressources humaines, je vous l'ai dit, j'ai compris qu'il y a l'outil informatique qui est utilisé, mais en termes de ressources humaines, qu'est-ce que ça coûte, qu'est-ce que ça vaut? Merci.
Thank you for the good presentations. Countries are Rwanda is experiencing a big challenge on. We've been engaged in reforms, starting with pilot as phases were explained last time, and there was a systematic review of the existing policy that time on a flat fee, and the study revealed that the flat fee was somehow regressive as a system where poor were subsidizing rich because they were paying the same amount, and the population, the poor segments of the population was in high proportions. this was a good information which informed a decision making. We embarked in stratification where population is paying currently based on the capacity to pay. But again, those reforms, the challenge we have is to have timely information to adjust, because it's a learning process. We are just going through something, we don't know exactly if it is appropriate. So the challenge now is to have timely information to make necessary adjustment on time. We have experienced decline in the coverage. So I don't know, I wanted to ask Joe whether there is a way or a mechanism to put in place, a simple mechanism, without maybe waiting for those systematic reviews or studies, a mechanism to inform as we go, as we do something to learn quickly and be able to have enough evidence to inform any decision on adjustments. Because, for example, now the level of premium, we don't know exactly whether they are responding to equitable share of burden among the categories. So that was my first question. And I wanted to commend the Ghana experience on this dashboard, which really is helpful. And I wanted to know how, basing on the different entities at the centralized level, how you centralize the information and how is the information at central level. Thank you.
Any other questions? We could take 3 before we answer.
Okay. Okay. Et merci pour toutes ces présentations riches sur le suivi et l'évaluation. Je voudrais poser la question c'est le Rwanda qui a présenté l'outil DHIS2 qui est utilisé au niveau de la collecte des informations, donc du système d'assurance qui est mis en place. Je voudrais au niveau du Togo, nous utilisons aussi cet outil en phase expérimentale actuellement, et en 2016, on est en train de le mettre à échelle. Mais on l'utilise uniquement pour les informations de routine, du système de santé de routine. Et je voudrais savoir si, dans l'utilisation que vous en faites, si vous intégrez les autres informations du système de santé de routine. Parce qu'à notre niveau, les informations de l'assurance sont gérées par un autre système. On n'a pas intégré les deux. Voilà, merci.
I think we'll take some answers first before we go on. I'll leave it to my colleagues to do most of the answering, but I think the first question about who does the data collection, do you have a special team or whatever? For me, the important thing is it should be institutionalized. The people who are doing the work or whatever, it should be some kind of routine that as you are doing your work, the data of what you are doing is being collected or noted or something, and your ICT systems should put it together for it to be looked at. Unless you're talking about those who are doing the analysis or something, but the actual data collection, it should be institutionalized. We should all be part of that data collection. But I'll pass it over to Joe and my colleagues to do more detail.
Well, let me try to respond to Dion's question about the updating of the kind of the contribution categories and so forth in Rwanda. It's a quite specific question. I don't know if there's a general answer, so maybe all I could say now is more in terms of principles. I mean, one is simply to recognize that with any type of targeting arrangement, we're trying to determine things that are not immediately apparent, who has the capacity to pay and who doesn't and how much, that whatever you do will be imperfect, right? And there's a bit of a trade-off between the cost and the complexity and the frequency of which you do this versus the accuracy and the timeliness of it. So I think in the case of Rwanda, I think my guess is a lot of it depends on the frequency of the community assessment mechanisms, right? Is it Udubehi or Ubudehi? No, that, which is done for a lot of things other than this. The only thing I guess I would say, at least for now, is again, to not wait, to start, each time you do it, start thinking about, how will we design the next time, and are we going to revise this within 2 years or so on. It's probably important to set a specific time frame for this, because if it's 5 years, that's probably too long, and 1 year is maybe too soon. So something in between is my, it's a very scientific answer. Thanks. For now. We'll see.
Ok, merci pour les questions. Je vais rapidement parler un peu de la question sur les ressources humaines pour la collecte et le rapportage et l'analyse. Pour cette question, je pense que, comme la chair a dit, il faut que ceux qui font les activités soient ceux qui font le rapportage. Au moins pour certains indicateurs, parce que ce sont eux qui font, au lieu d'avoir un système parallèle. Mais ce que je veux ajouter, c'est que il faut qu'il y ait un système de feedback direct. Parce que quand on fait le rapportage et il n'y a aucun système de feedback, on finit par se lasser de toujours rapporter les indicateurs. Et c'est pour ça que l'exemple que nous avons choisi de donner aujourd'hui, celui qui fait entrer les données voit déjà ce que les données signifient pour son institution. Mais je sais que dans beaucoup de pays, il y a un challenge, parce que j'allais dire qu'il faut que ce soit web-based. Donc, web-based, je ne sais pas comment on dit ça en français, mais que ce soit accessible de partout. Et on a un problème d'électricité, on a un problème d'Internet, on a un problème de tout ça. Alors, un des arrangements, c'est que il peut y avoir comme des fiches de rapportage. Et le niveau, comme au Rwanda, c'est le district, là où vous êtes sûr qu'il y a l'Internet et l'électricité. Donc, les sections ou bien les centres de santé peuvent rapporter au niveau des districts et c'est le district qui fait entrer les données. Donc, il peut y avoir un arrangement pour voir quel est le niveau où c'est facile d'entrer les données dans quelque chose qui est web-based, qu'on accède à travers l'Internet. Et donc, l'idée là, c'est vraiment le feedback pour ceux qui entrent les données, afin qu'ils puissent se corriger et prendre les actions. Pour l'autre question qui a été posée, sur le DHIS2 par le Togo. Au fait, j'avais un peu expliqué, c'est parce que j'ai survolé. Au Rwanda aussi, il y avait des systèmes de rapportage standing alone. Donc, pour chaque partie, l'assurance à part, les hôpitaux à part, donc HMAS, le district à part. Et c'est comme ça qu'on a évolué vers le DHIS2. Le DHIS2, c'est le District Health Information System. Donc, au fond, c'est pour vraiment avoir un dashboard pour tout ce qui est secteur santé dans le district. Ça signifie, comme maintenant, les mutuelles de santé, progressivement, on a intégré toutes les bases de données. On a commencé par HMAS qui était pour les formations sanitaires. On a ajouté une autre base de données qui était du paiement basé sur la performance et on a ajouté la base de données des mutuelles de santé, donc progressivement pour arriver à quelque chose d'intégré, juste une base de données où on peut avoir accès. Et comme le Ghana avait dit, on a un dashboard, donc tu peux facilement utiliser les indicateurs de n'importe quel sous-secteur pour avoir une analyse d'ensemble. Je pense que j'ai bien répondu. Merci.
I think in the earlier discussions in the week, the issue of integration came up and having a unified system. For those just starting, you need to maybe develop unique ID codes for your health facilities and begin to think along those lines of when we are integrating, how easy is it going to be? What do we need to make sure we have in place? And it's the technical people who can do that. as a country, we now have a data dictionary so that everything is defined and the format it should be in, so that even if you have separate databases, we can eventually work towards integrating these databases, because we know we're talking the same language with the same codes, etc., for the health facilities, for the medicines, for the procedures or whatever. And then you can begin to integrate the different databases.
On that as well, to say that this is really, this is a core responsibility, as I would see it, of the health ministry. I mean, there's lots of things that agencies like Health Insurance Fund can do and so forth, but the responsibility, in terms of a kind of a core regulatory and policy requirement to insist that there be a unified system, even if there's multiple schemes, or even if not everyone is in the scheme. It's really, I think, important, especially from an early stage, to try to start this in a unified way, because once it's fragmented, interests develop and power bases develop, and it can be difficult to bring it back together. So it is important to think about, in a sense, even before you have a universal health financing arrangement, to have a universal data system in that sense that enables you then to move in that direction.
Toutes nos félicitations aux présentateurs. Je pose ma question parce qu'elle n'a pas été posée. Et aujourd'hui, un des défis majeurs, comme vous l'avez dit, c'est la mise en place des systèmes de suivi et évaluation performants. Aujourd'hui, on parle de cette réforme de couverture sanitaire universelle. Il faut aussi, c'est la deuxième fois que je pose cette question dans des conférences internationales, qu'on aide les pays à définir un paquet d'indicateurs par intervention. Sinon, ça risque d'aller dans tous les sens. Il faudra non seulement définir le paquet minimum d'intervention de chaque indicateur, de chaque intervention, quels sont les indicateurs minimums, la méthodologie de calcul pour harmoniser. Et ça, je pense que Dieu est en train de rigoler. Il faut qu'ils aident un peu les pays à définir, comme le VIH l'a fait. Il y a eu des définitions des indicateurs par intervention, la méthodologie de calcul. Et c'est vrai que chaque pays a un système, les systèmes sont différents, mais je pense qu'ils aideront les pays à avoir un paquet d'indicateurs, la méthodologie de calcul. Avant même de parler de la mise en place des systèmes, la première étape, c'est la définition des indicateurs. Quels sont les indicateurs qu'il faudra calculer pour chaque type d'intervention? Merci beaucoup.
Merci beaucoup. Moi, j'ai juste deux questions pour le Ghana et de manière générale pour également les pays, en tout cas, qui ont un système de suivi et évaluation pour aller vers la couverture sanitaire universelle. La première, elle est relative à l'intégration de la consommation des médicaments dans le système de suivi et évaluation. Est-ce que vous avez aujourd'hui un mécanisme qui vous permet de suivre la consommation dans les différents systèmes d'assurance maladie? C'est extrêmement important pour nous de le connaître, parce qu'en fait, si l'on sait qu'aujourd'hui, le rôle extrêmement important que joue le médicament dans le protocole. L'autre question, c'est par rapport aux indicateurs de suivi. Généralement, les pays ont des indicateurs de suivi classiques, des indicateurs de santé de manière classique. Mais est-ce qu'aujourd'hui, au Ghana, par exemple, il y a dans le système de suivi et évaluation un système qui nous permet de mesurer aujourd'hui les gaps en termes de ressources humaines, en termes également de structures de santé qui sont en train d'être mises en place dans le système? Ça également, je crois que c'est extrêmement important, parce que quand on est dans une perspective de couverture sanitaire universelle aussi, on doit pouvoir suivre aujourd'hui l'évolution des indicateurs qui sont relatifs aux ressources humaines sur le terrain, mais également aux infrastructures et aux équipements. Est-ce que ce dispositif existe dans votre plateforme de suivi et évaluation? Merci beaucoup.
I think we'll answer these two questions and then get to the work section. The two questions specifically addressed to Ghana are monitoring of HR and infrastructure. Yes, we do that, but it isn't on our dashboard. That's why it wasn't mentioned. But actually, due to the capitation, it has become incredibly critical for us to know where the services are. If we're going to capitate people, we need to know where the services are. And what we have done is, or are still doing, is health facility mapping, where we're using GPS coordinates to know where each facility is, the basic equipment they have, and the staffing they have. And this, they've got all sorts of charts and whatever, and it's part of the capitation rollout, because we need to know that the primary health care minimum benefit package is available in every part of the country for our members to attend, and it's an ongoing process. The integration of consumption of drugs, that is a challenge, because to really monitor it well, you need to know what is coming into the country, what is being manufactured, what is being registered by the Food and Drugs Authority, where it is being retailed at, which patients are getting it for what. We do not have that kind of comprehensive setup yet. Different agencies are still regulating different aspects of the pharmaceutical supply chain, and it's a real challenge for us. But at health insurance, we realize the amount of money we spend, and therefore, because we now have electronic claims data, it's a little bit easier to really track the consumption. And some patterns have been identified. Funnily enough, we have operational research that has just started, a quick win research over 3 months on malaria, how malaria medicines are being used in this country. So within about 3 months, we should have some information that we can liaise with the ministry and the National Malaria Control Program on how effective the malaria treatment is, whether what we're doing is cost effective, does it follow WHO guidelines, etc., etc. But we don't have the fully integrated systems that would allow us to monitor drug consumption effectively. Over to you.
Thanks. Before getting to the easy question about the benefit pack, or let me just say quickly, there is no internationally defined benefit package in the way that there are specific protocols and interventions for specific diseases such as for HIV. I think the issue is more about your domestic priorities, right? And also, I mean, one thing that's important to keep in mind is that, you know, whether it's explicit or implicit, countries you already are providing certain services, and there already is, to some extent, a benefit package. And typically, the process of adjustment to that is incremental, right? So I think it's I don't have really an answer to say, you know, this is what you should focus on, but the issue is more to say what you're, you know, both what you're doing and then an assessment of your priorities can give you an idea of what needs to be monitored in that regard. I do just want to give an example also, the medicines issue, because I think it's another useful example from Kyrgyzstan, which is quite concrete. When they introduced an outpatient drug benefit package, it came with its own data system, and it was based on prescribing form that basically the primary care provider would use this. They would complete the form. It had their own code on it, and the patient name and information, the medicines, and so forth. And the doctors would submit that to the health insurance fund. The patient would get 2 copies of that form. They would go to the pharmacy, give one to the pharmacist and get their prescription filled, and the pharmacist would then send that to the health insurance fund. So what this allowed was basically, and what the insurance fund was able to do with this, was analyze prescribing patterns by the providers, determine the extent to which people who received a prescription actually got it filled, and use that as a basis for finding out what was going on, and also to look at whether the prescribing was actually consistent with the diagnosis as well. So there's just, again, an illustration that if you design these things well, they can offer quite powerful information about how the system is working and what problems you may be having.
Okay, thank you. Now, to make sure the panel are not the only ones doing some work, we're going to throw a few things at you, and Danielle is kindly going to put things, use the flip chart. So looking at institutionalizing roles and responsibilities where this evaluation and operations research are concerned, and using your own country experience, if we could have a few challenges with regards to this and some solutions to get around the challenges. So institutionalizing the roles and responsibilities to do with intelligent health systems, if we could have some suggestions here. What do you see as some of the challenges with this that your countries may face? And once we've got a few challenges up, we can come up with some solutions to address this in our specific countries.
Before facilities are allowed to come on insurance, they should be told exactly what the data expected from them. They should be told, are we to give to you itemized medicines, what type of services? They should be told exactly what we want from them. And it should be standard across board, so that we can get the data we want. And if they do that, it will help. It will help the country. For if facilities or if providers submit different format, different data, it becomes difficult analyzing. So from the very word go, from the onset, they should be told what to do. Thank you.
Thank you. So that's an institutional responsibility that the providers should face. Anybody else on data collection, monitoring, evaluating, some of the roles and responsibilities of do we have any representatives of ministries of health in the room? I think we'd like to hear from you, because most of us believe that you should be taking the lead on this.
Merci. Je suis le docteur Kwadjo Ghislaine, je suis du ministère de la Santé de la Côte d'Ivoire. Nous également, pour accompagner la couverture maladie universelle au niveau du ministère de la Santé, nous avons élaboré un plan stratégique de renforcement du système d'information sanitaire. Et dans ce plan stratégique de renforcement du système d'information sanitaire, nous avons mis en place divers systèmes intelligents pour pouvoir capter l'information, à savoir déjà déployer le logiciel DHIS2 dans toutes les régions sanitaires du pays. Nous avons 20 régions sanitaires. Nous l'avons fait en décembre 2015, nous avons déployé ce logiciel à travers tout le pays. Également, nous avons un système de gestion des médicaments, notamment avec le logiciel ILMIS, et également au niveau des laboratoires avec le logiciel OpenELIS. À côté de cela, nous avons mis en place un système d'informatisation au niveau des points de prestation de services, notamment la mise en place d'un dossier patient médicalisé. Également, penser à informatiser et interconnecter toutes les structures sanitaires et le rendre interopérable avec le système de gestion qui sera mis en place par la Caisse nationale d'assurance maladie. Donc, c'est un peu cela que nous faisons en Côte d'Ivoire. Merci.
Alors, nous également, au niveau de la Caisse nationale d'assurance maladie en Côte d'Ivoire, nous avons déjà eu plusieurs séances de travail avec le service informatique du ministère de la Santé pour voir comment est-ce qu'on peut faire l'interconnexion entre leur logiciel et nous, non logiciels. Parce que nous aussi, on a une grosse base de données qui va capter tout ce qu'il y a comme prestation. Vous avez montré par exemple la feuille maladie ici. Et nous, il faut que toutes les informations qui se trouvent sur une feuille maladie puissent être intégrées dans notre logiciel pour que nous on puisse produire des données, faire des analyses et faire des orientations en termes de politique de santé et tout ça. Donc, pour faciliter les choses avec le ministère de la Santé, nous travaillons à interconnecter, créer une interface pour pour les différents logiciels, de sorte qu'il n'y ait pas à dupliquer chaque fois les informations. Donc voilà un peu le travail synergique que nous faisons en Côte d'Ivoire.
Okay, let's go to the next thing, feedback loops. We are all collecting data doing analysis. Many people in this room work at the central level. How are we ensuring the feedback to, one, the staff who are collecting the data, to the implementers, to the policymakers or whatever? How are we ensuring that the data we're collecting and the analysis has some use outside our offices? Any contributions here?
Voilà, merci beaucoup. Donc pour le Sénégal, je crois que les décideurs donc, ont veillé à ce qu'il y ait une plateforme de revue annuelle des politiques publiques. Et ça, souvent, c'est un conseil présidentiel où tous les ministres viennent et rendent compte des résultats de leur secteur annuellement. Et il y a des indicateurs donc, qui ont été bien identifiés par le secteur et qui sont restitués. Donc ça, c'est vraiment pour permettre à l'autorité, à un plus haut niveau, de voir donc, quelles sont les performances donc, enregistrées au cours de l'année et quelles sont aussi les mesures de correction à apporter. Donc cela veut dire qu'avant la revue annuelle, avant le conseil présidentiel de suivi, il y a des revues sectorielles qui se tiennent. Et le ministère de la Santé organise sa revue annuelle sectorielle avec l'ensemble des acteurs de la santé, société civile, secteur privé, partenaires techniques et financiers. Donc ça permet au niveau donc, du ministère de la Santé de voir la situation, les indicateurs, les performances. Donc je crois qu'il y a un dispositif de suivi et évaluation interne au ministère de la Santé. Et l'agence qui s'occupe de la couverture maladie universelle doit renseigner par rapport aux indicateurs qui les concernent. Ils ont des activités à mener, donc c'est eux qui fournissent donc, les inputs donc, à une direction de la planification au niveau du ministère de la Santé qui recueille les données, qui collecte les données. Et de là aussi, il y a des recommandations qui sont formulées. Donc nous, au niveau du ministère de la Santé, nous pilotons le processus de revue annuelle donc, qui se tient en conseil présidentiel. Voilà, merci. Voilà.
Okay, that's a bottom-up feedback. Often the top-down feedback doesn't work so well in most of our countries. Suggestions and ideas there.
Par rapport au Togo, notre défi actuel, c'est de faire l'extension de la couverture publique, couverture santé au niveau des agents du secteur public, vers les autres secteurs, le secteur informel et autres. Et dans le cadre de cette extension, il est prévu on va en même temps essayer d'identifier les indicateurs de couverture de santé, couverture universelle, pour intégrer dans le document, dans le plan d'évaluation, de suivi et évaluation. Et étant donné qu'en 2016, nous allons mettre à échelle le DHI 2, il va falloir, puisque c'est un outil au niveau du district qui ne comporte pas tous les indicateurs, donc il nous faut actuellement essayer d'intégrer les indicateurs concernant la couverture santé et reparamétrer cet outil de suivi pour l'intégrer. Donc on va avoir un outil intégré de suivi au niveau du district. Donc c'est actuellement notre défi au niveau du Togo.
Je trouve que c'est bon de pouvoir, on collecte les informations, on les remonte, on élabore des rapports annuels sur la situation sanitaire. Mais ceux qui collectent, est-ce qu'ils ont une idée de la qualité et de l'information dont ils disposent? Qu'est-ce que cette information-là peut servir? Ils ne savent pas. Donc notre challenge au niveau de la Côte d'Ivoire, c'est de renforcer les capacités des acteurs à tous les niveaux du système à l'utilisation de ces données qu'on produit. Au niveau même du décideur, qu'est-ce qu'ils ont fait lorsqu'on lui remet un rapport annuel? Qu'est-ce qu'ils ont fait? Souvent, ils l'utilisent, mais bon. Mais on veut une utilisation optimale de ces informations-là. Au niveau du prestataire même qui collecte ces informations qui remontent au niveau central, qu'est-ce qu'ils ont fait? Est-ce qu'il peut les utiliser pour pouvoir prendre une décision de façon réactive, à l'instant même lorsqu'il constate des écarts, et les faire remonter au niveau de la pyramide sanitaire? C'est notre challenge. Donc, il faut renforcer les capacités des acteurs à tous les niveaux de la pyramide sanitaire à l'utilisation des données qu'on produit.
C'est une petite contribution. Moi, je crois qu'en termes de mécanisme de suivi et évaluation, on est souvent très ambitieux d'avoir toutes les informations à un et seul même niveau. Et je crois qu'il faut qu'on soit prudent par rapport à ça. Si je vais au niveau des systèmes de santé, habituellement, ceux qui collectent les informations et qui sont les prestataires sont sous pression. Ils n'ont pas le temps de revoir ce que ça a donné réellement. Habituellement, les niveaux les plus élevés, pour prendre le cas du pays que je connais le plus, le Bénin, c'est qu'il y a des injonctions du niveau supérieur pour valider la qualité de certaines données. Et ça, c'est un mécanisme important de descendre sur la base d'un échantillonnage pour valider un certain nombre d'informations. Mais ce qui serait beaucoup plus intéressant et rationnel pour ceux qui collectent l'information, c'est qu'à ce niveau-là, les responsables, par exemple au niveau de ce que l'on appelle zone sanitaire, aient au moins mensuellement le temps de travailler ou de refléter, d'expliquer ce qu'a donné les informations qui sont envoyées au niveau de la base, qu'on a eu à étudier, qu'on a eu à synthétiser, à analyser pour dire voilà ce que ça retourne. Pour dire oui, ce que vous collectez est bon ou n'est pas bon. Voilà la décision que nous pouvons prendre maintenant par rapport à ça. Sans ça, on ne fera rien parce qu'ils collectent les informations, ils n'ont pas le temps. Et même si on fait une synthèse, un rapport, qu'on le leur retourne, ils n'ont pas le temps de le lire ou parfois pas la capacité de comprendre ce qui s'y trouve. Donc, il serait intéressant de s'asseoir toujours à un moment donné, une périodicité qui serait fixée pour passer en revue ces informations-là, ces indicateurs-là, afin que les décisions hardies, idoines soient prises. Voilà ce que je peux dire, au-delà de ce que le collègue du Sénégal a dit, qui est le temps qu'on se donne au niveau plus stratégique pour faire le suivi et évaluation d'ensemble de ce qui se passe au niveau soit d'un département ou du pays. Je vous remercie.
I think we've had two really valid points here. One is from Côte d'Ivoire, the data collection. We keep talking about decision makers and policies and the president and all that. But at the lower levels, at the people who actually do the collection, if their capacity is built, they could make interventions even at that level to change the data, to improve the quality, if they know how to. And I think it's something we sometimes forget. We're so keen to collect it all for the top that we forget those at the bottom. Then the other thing which I think pertains to Ghana is that we want it to be institutionalized, but it's those same workers who are actually caring for the patients. They are the ones doing the service delivery. When there's so much pressure on you to fulfill your core mandate of caring for a patient, how do you then also input the data that is required? And if you are not, or you do not understand the benefit of that data collection to you, you end up just putting in rubbish just to be able to fulfill your requirements. Time is against us, but I want to throw in one really awkward question. All the countries represented here, we have some obligation to the development partners, and this comes with indicators and data collection. Are these requirements making things better or worse? The indicators and pressure from the development partners to report on some of our health systems. And sometimes these are not indicators that the country may consider a priority or necessary. Do we think some of this makes things worse or better? That's a tricky one. Let's get some responses.
Alors, au niveau de la Côte d'Ivoire, pour lancer la couverture de maladie universelle, nous avons fait une petite étude sur la qualité de l'information sanitaire. Alors, le constat frappant est que les informations provenant des programmes soutenus par les bailleurs de fonds étaient disponibles. Parce qu'ils installaient, ils donnaient comment vous appelez ça, un canevas de rapportage de leurs informations. Et ces informations, celui qui les renseignait avait une motivation pour renseigner ces informations. Donc, quand on cherchait les informations sur le VIH-Sida ou la planification familiale, on l'avait. mais les autres informations usuelles qui concernent les autres services de la santé, on avait des difficultés à avoir une complétude dans ces informations-là. Donc, du coup, les bailleurs de fonds, je dirais, dérèglent un peu, dénaturent un peu le travail dans les services de santé, puisqu'il y a une certaine préférence qui s'installe au niveau de la compilation de ces informations, et ça nous pose problème. Alors nous, on s'est dit, au niveau de la Caisse nationale, il faut mettre en place un système qui fait en sorte qu'on puisse uniformiser ces informations pour qu'on ait les informations les plus complètes possibles sur tout ce qu'on veut avoir comme information sanitaire, et non de manière disparate, selon que ce soit appuyé par un bailleur ou pas. Donc voilà un peu le constat que nous avons fait en Côte d'Ivoire.
Merci Madame la Présidente. J'aimerais rajouter, il y a un principe qui me plaît, que j'adore, c'est l'IHP+, International Health Partnership. Et les principes disent que les partenaires qui viennent nous appuyer doivent s'aligner à nos procédures. Donc les partenaires qui viennent nous financer, renforcer nos systèmes, doivent pouvoir nous amener à avoir un cadre unique de suivi et évaluation, et appuyer les systèmes de santé à pouvoir disposer de choses, d'indicateurs qui seront pertinents pour le pays et qui seront à même appuyer le pays à pouvoir collecter ces indicateurs-là, et non pas à verticaliser chaque niveau de collecte de l'information sanitaire. Par exemple, le Fonds mondial, je ne veux pas citer quelques partenaires, mais on trouve qu'on a plus, les données sont plus complètes au niveau des 3 maladies du Fonds mondial: paludisme, tuberculose et VIH-Sida. On aimerait qu'on renforce notre système national d'information sanitaire, de telle sorte qu'on ait des informations uniques et de qualité pour prendre la décision. Merci.
Okay, I think now I'll ask each, time is up, so I'll ask each of the panelists to 1 minute to sum up.
Thank you very much. I have a few ideas. Of course, first of all, in the data collection system, who should collect the data? I strongly believe that the one who is providing the service to the patient, to the customer, should really register the information that he has provided or that she has provided. So it's not usually comfortable to make one data registrar and the one providing service, because the one who provided the service knows what he did. But between support partners and the government, they should sit together, select the indicators, and agree on the indicators, so that it should be, in Ethiopia it's working very well, that there is only one source of report, and together they analyze and provide feedback, so that it's very difficult. It's another additional burden to the healthcare providers to have 2 or 3 type of reporting systems. So it should be synchronized. In Ethiopia, we have the HIT, Health Information Technicians, who have diploma level knowledge of healthcare and diploma level of knowledge in IT. So this synchronization has made in every health center, we have 3,600 health centers and 1 HIT in every health facility that rotates around and supports the healthcare providers how to register, how to complete, and how to do things. So that this is an extra supporter. So we have also this type of system. Thank you.
Okay, thank you. I'm going to just make 2 points. The first one is about the feedback. I think someone talked about it there. For my personal advice is to have a permanent feedback. And now we have quite good technology that is possible. Through dashboards, as we had an example from Ghana, through simple Excel sheets with some colors. So for me, a permanent feedback, because when we talk about building capacity in data analysis, it's not that easy. But when someone has an easy way to get feedback for what he's doing, I think it's always better. So sometimes to have findings after 1 year, it's too late. After a quota, it's too late. But when it's permanent, then people are motivated to take some decision. The second thing is about the reporting, and I think what is true is that it's a challenge when health facilities or health insurance schemes have to do many reports. And I think that was the case in Rwanda, but the government must be strong enough to harmonize, to do the follow-up and harmonize the reporting systems and have one reporting system where people can use data according to their own preferences. May it be, because sometimes we talk about partners, but sometimes it's departments within a ministry. They have also different reports. This is for malaria, this is for HIV, but when it's integrated, then for the use at national level or at a higher level, anyone can conduct their own analysis. So maybe those two are my points. Thank you.
Thanks. This, for me, was a very important session. I think that really having systems that are learning, that are adaptable, is really essential for making progress towards UHC, for making progress on your objectives. And it's getting the particular instruments of health financing and service delivery right is important, but no reform plan is perfect. And situations change over time. So really to have a sustainable system in a way is about your ability to generate, analyze, and adapt to information on what's happening in the system. So in a sense, not just, like we've been saying, not just as an afterthought, but as an integral part of your health reform plans and strategies is to think about how can we strengthen and institutionalize processes for evidence-informed decision-making and really make that part of the culture of our health system. Because otherwise we'll keep coming back to starting over periodically and chasing after things. So it's really fundamental to the changes that you're trying to make.
Thank you. That's the end of the session. I want to thank everybody for participating. I think for those of us up here, I think this whole monitoring and evaluating and assessing yourself as we move along this path to UHC is really important. And we have to get away from M&E being some special something that we do after we've got a project going. We need to begin to make it part of the work we're doing, part of the implementation. It should be routine, day to day. And I think from the feedback session we've had, I think most of us are beginning to think that way and work that way. It's the best way to achieve progress. Thank you all for taking part.